Hi everyone, very good evening to all, and I welcome you all to this first session of the one-shot series of DBMCI. And I am Dr. Sushil, your orthopedic faculty here at DBMCI and Gurukul, and I'm going to cover up the orthopedic part today. So before I go with any further like this orthopedic part, let me just tell a few things. Let me just inform you a few things, guys. I've been just before I started my session, I've been watching your comments on the YouTube, this channel of DBMCI, and to be very honest, not very happy with the way you guys are putting the message over there. So we being medicos, I think we should maintain some little decorum at least, isn't it? And that is only thing which is being taught in medical colleges, that to respect like the sessions, the medical things or the academics that you might be getting from anywhere. Okay, so really not very happy with the way the things are being put. And I'm okay if you have some anguish against somebody, if you have some anger against somebody, I'm very much okay with it, right? But there is a way to put it, and if you feel like that there is something which can be improvised at the institutional level, then I do believe that all the students of DBMCI, they are very much connected with me on the Telegram groups. For all your concerns, all your issues, you always have been tagging me there, right? And I don't think any member of the DBMCI has ever said no to any of your problems. If they were solvable, they were done. So putting these kind of messages no doesn't serve any purpose. It makes you lose your energy, and it is better at this point of time when all the exams are announced. We should be staying little positive, right? So if there is any challenge, any other problem, any complaint you have with anything in DBMCI, feel free to just connect with me, and I'm assuring you that things will be taken care of. So like let me just answer a few other questions as well. Okay, so why are they conducting it YouTube for free? 999 wasted, could have watched for free. So let me tell you guys, today is my orthopedic session, and there are questions regarding the one shot program. So first of all, let me tell you what a one shot program is. One shot program, it is all about revising all your 19 subjects in a very quick span of time, and for that a dedicated schedule has been made for you. We are starting today, that is the 9th of April, with the subject of orthopedics that I'll be taking care of. After that, every day we are having the subjects continuously, and every day one subject will be completed. One shot revision, it is going to make sure that we revise the most of the part of the subject, along with taking care of all your previous year questions as well as the topics. That is one thing that will be covering majority part of all the questions, all the topics which have been asked, not only in the NEET exam but for INA exam as well. That is other one. Another important point is that yes, we are going to take care of how the questions can be framed in the upcoming session as well. Okay, so every day we are having a class. Today I'm starting with my orthopedic class. Then we have a class by pathology of the pathology subject by Dr. Praveen. Then we have biochemistry class, then we have microbiology class, then we have psychiatry class, and that is all happening like in a row. So 9th, 10th, 11th, 12th, 13th, 14th, 15th, 16th, 17th, 18th, every day you are going to have the class starting at almost same time, and then the whole subject is going to be revised. Another very important point is, yes, it is not free of cost. It has to be relayed only on DBMCL Live, but there are so many students who are not very sure what a one shot is and how does it look like to revise the subject in a very quick and short span of time. Okay, and that is why this is being relayed on YouTube for a fee. So those students who are enrolled with us, there is no need to get disheartened that you could have seen this thing for free. It is not going to happen. Just to give an idea to all the students on the open platform that what one shot is, this session is being conducted so that you have an idea. So if you are the one who is actually done with the subjects once, if you're the one who is looking forward to just revise everything in a very quick span of time, if you're the one who have been very consistent with your GTs, who have been very consistent with your subject, the cumulative test or whatever you have been giving at your platforms, so you are really the one who will be benefited by it. If you are thinking that this one shot is going to remove the need of reading the whole subject, that's not going to happen. It is a revision program. It will be very quick, presuming that you already know everything about the subject, right? Yeah, so then you have the first class free for more publicity. That is true. It is for publicity, to tell everybody that there is something called as one shot which is beneficial for the students, and that can definitely make an or give you an extra edge when you are solving your MCQs. Definitely that is that. Okay, so if anybody, I can see Arben is putting a message that if you haven't got the activation and if you're watching me live, just put a message to your batch buddy, okay, and that will be activated instantly. My team is there on the backup, and if you put a message to them, batch buddy is there, Bhavna is there, Anil is there, if you can just put a message to them, please, that will be done instantly. Okay, so initially there will be some time when we are live on YouTube. After that, I'll be shifting to DBMC live only. But till that time, if anyone who is watching me live here and who has subscribed, definitely you can just put a message. It is going to be sorted out. All right. So, right. So, hi everyone. Good evening, Jawad. Good evening, Sim, Simani, Krishna, Parthe, Abhirami. Good to see you all, guys. Okay, so good to see you, everyone. Is this session for FMG also? Definitely, you can utilize this session for FMG. Why not? Questions are going to be same in the exams. Only the way in which the content is asked is different in FMG or NEET or INI. Content is same. If fracture shaft or femur has to be asked, it will be asked in all the three exams. The way in which it is asked is going to be different. Okay. So it is not opening an app. So please, anyone, DBMCA enrolled students, if anyone is facing any problem anywhere, feel free to please put a message to your batch buddies and things will be taken care of. Yeah, okay. Can we do chat in DBMCA? Yes. So all the students, there is a Telegram group. I'm sure that each one of you might have got the link for that. While all the faculties will be discussing the one-shot program with you, the Telegram group discussion will be on like you normally do in all your regular batches, DBMCA like post-intern batches. So it will be open. And yeah, you can ask me the question. No worries at all. You can ask me the question on the same Telegram group. I'll be there. I'll be just opening my Telegram group in a while after I just finish these messages. Okay, so one shot, yes, it is good for NEET, it is good for INI, it is good for FMG, and in this, every faculty is going to make sure that yes, NEET started in 2020, we had this INI exam, and we are going to cover each one of them, right? All the PYTs, all the PYQs will be covered. For sure, it will be covered. PDF and PDF and PDF. So let me tell you guys, I don't have any PDF for you. Okay, you have to write down along with me. Once the session is done, definitely I'll be sharing certain images with you. That is for sure. I'll be sharing some images with you which will help you to recall the content that we are discussing right now, because this one shot is going to stay with you in your DBMC Live app. Okay, so it will be there once whatever we are discussing today on this platform DBMC Live, it will be recorded and it will be there on the DBMC Live app for you. So if you miss by chance some part of it of some subject someday, you will always have a backup plan. Okay, so the live classes, yeah, questions will be there. So fine, yeah, PYQs are covered 100%. Express revision notes, if you are using the notes, you can use anywhere you want, but I want you to highlight them very, very properly, because at the time of revision, it will be a big trouble. Okay, so team, if you can please just see the students who are having a problem, I'll just tell them to just have a look. Okay, so let's go. Yeah, Viman is ready. Great, Viman. We are just starting. Check for the live session. Team को बोलो उसमें check करने के लिए. The students who are not on the app, help them out. So everyone who is watching me right now, you have got a link of the Telegram group. Okay, once you have got enrolled, so Telegram group, in that group itself, you just please put a message. My team is there, and they will make sure that you are. Yeah, we should write in the old notes or better make new one. So anyway you can do, I would just recommend that you just keep your notes open, the orthopedic part, and wherever you feel like there is some like tables or there is some compilation of the content, you can definitely note them down. So put some sticky notes or put some A4 size paper with you. All right. So the schedule is fixed, guys. One shot, quick revision of all the 19 subject. Every day we are going to have the session in the evening hours, complete subject along with the questions of NEET, INI and the FMG. For everyone, it is going to be very, very important. No doubt in that. And if you are prepared for a quick recap, then definitely this is a program for you. All right. Okay. So please put a Praveen, please put a message in the Telegram group. Let me put the link of Telegram group here as well. Those who are DBMC enrolled student only will be able to get the DBMC live class. Okay, I'll just put the link for my Telegram group. So all the DBMC enrolled student can please go to this Telegram channel. I'm just sharing the link with you. Okay, so this is the one. So I've shared in the live chat as well. So those who are enrolled, guys, please go to this link. I've shared one link in the live chat section. Okay, so I think we are ready to start now, and all your grudges, all your anger would have been like little calm. Okay, so don't get annoyed, guys. It is okay. We are grown up, we are mature now, and we should know how to control these things. Okay, and don't let that negativity or that kind of thought processes just conquer your mind. It is not going to be very fruitful in long run. Otherwise, you are going to have the same negative thoughts all the time in your exams, all around your patients, in your life. Don't do that, right? So let's be little positive, let's be little hopeful, and let's be little thoughtful what we are saying or what we might be doing, right? So we are ready to start, I think. Okay, so duration of the class depends on the faculty and the subject. So my duration will be like we are going to finish today only. So let's see. If we start, we can should just somebody ask me a question, will he be able to complete orthopedics today? I'll try my level best to give you the best of the content I can for orthopedics part. So yeah, Utkarsh, PT, Krishna, Satya, ready, Abhay. Okay, fine. We are ready to start. So guys, now we start with the part of orthopedics, and I'm starting with the trauma section. How the questions can be in your NEET, in your INI, in your FMGs, all the topics, the important ones. Let's start with that, right? So trauma. Yeah, great, Himani, Vivek. Let's start with this. So trauma, you know that trauma for us is what? It is simply a fracture, isn't it? Fracture, how do we define a fracture? When you look at the structure of the bone, you know very well that the bone, the basics for those who are watching me for the very first time. So I'm just telling you what exactly the bone, how is it defined? So this is, let's say, some bone, okay? And when you look at this bone, there is a protective membrane. There will always be a protective membrane onto the bone, and that membrane is what we call as the periosteum, right? That membrane is what we call as the periosteum, right? Now, before I go ahead, let me show you what a periosteum actually looks like, and that is going to be very, very fruitful to each one of you to understand forever in your life, like why to understand the periosteum and the bone was important. Let me show you one video here. Okay, so I'm just opening up a video. Just allow me one moment, and I'm just showing you how the periosteum is going to look like. So this is something which always confuses us when I'm talking about the bone, when I'm talking about the periosteum, the fractures, the tumors. What helps me out, right? What helps me out? Okay, so let me just, oh my bad. Okay, so have a look on this. Yeah, now I can show you this. Yeah, look at this. So this is one video where we were operating on a lady who got injured ankle. Okay, and I'm just having this forceps in my hand, and in my right hand we have this periosteum elevator. Okay, so now I'm just doing some cleaning of the bone. Muscle is attached to it. Then I'm holding on to the surface of the bone, and just have a look. I'm entering between a area where the muscle is attached to the bone. Periosteum goes in again, and we are trying to scrape up some area. Can you see that membrane? Can you see this thin membrane there? This one, this is what you call as a periosteum. Now this periosteum has a role to play in number of MCQs for us. How that helps. Let's understand. So this membrane that you're watching in front, which I'm holding right now, is what we are calling as a periosteum. Okay, so let's talk about this. Let's talk about our lecture. So this periosteum, okay, which I was just showing you now, how this helps, how this gives us the MCQs. So guys, this one, when you talk about the bone here, now when you talk about the bone here, okay, right, so this one is the bone, and on the surface of the bone we have got this periosteum, right? This is the periosteum we have. So how do we define a fracture? Fracture is defined as a breach in the continuity of the cortex of the bone. This is what you are calling as a cortex, not the periosteum. So periosteum can be intact. Now this periosteum that you have just seen is the reason for so many things. The periosteal reactions in your malignancies, the Codman's triangle, the onion peel appearance, sunburst appearance, periosteum in an open fracture and a closed fracture, what a role it has to play. This periosteum on its outer surface here, it is giving attachment to the muscles, but on the inner surface, it is connected to the bone. So the outer surface is giving attachment to muscles. You know so many origin and insertion of the muscles, and you know very well that this muscles, basically none of the muscle is going into the joint area. right? Reason being, muscles don't get connected to the joints or the bones, they get attached to the periosteum. Second thing, internal part of the bone or the periosteum, basically the inner part of the periosteum, is called as cambium layer. Now what is that cambium layer? It has got an osteogenic potential. That means it can make a new bone. So whenever you're talking about the healing of the bone, whenever you're talking about the callus around the bone, whenever you're talking about onion peel appearance, Codman's triangle, or any of the other periosteal response like sunburst, it is the cambium layer which is going to give the response. This is the reason why we need to understand the difference in an open and a closed fracture. Now, open fracture, we all know that is the one where the fracture site, this fracture site, which you can see here, this fracture site is having a communication with the external environment, right? Why should I call this fracture as an open fracture? If the blood from this site, it can go out from here. It simply means that the infection also from environment can go in via same route, right? So why we are worried in open fracture? The infections. Okay, so open fracture, closed fracture, which one has having a better prognosis? Always a closed one, because the periosteum would be probably okay, right? The infection chances will always be less. Question number 1, which comes from trauma, it is about, okay, so what is the classification that you use for the open fractures? We know that the classification to be used is Gustillo Anderson classification, right? The Gustillo Anderson classification. All right. In Gustillo Anderson, please don't forget, we have got 3 kind of injuries. Number 1, the first injury we have is the clean wound. Any clean wound which is less than 1 centimeter, right? Any clean wound which is less than 1 centimeter. Second injury is when the wound size now gets more than 1 centimeter. When the wound is now more than 1 centimeter and the soft tissue injury is not very severe. Okay, so soft tissue injury is not extensive. Soft tissue is not extensively damaged. That is type 2 and type 3. And type 3 is the one, okay, type 3 is the one where we have extensive soft tissue damage. Where we have extensive soft tissue damage, right? What is the meaning of this Gustillo Anderson? Simply, it is telling you about the open injuries, open fractures. So extensive soft tissue injury. Now this extensive soft tissue injury, it divides further the grades into 3 types. Type 3A, what is that type 3A? It is the one where the periosteum, basically the bone, is having multiple comminuted fragment. So bone is comminuted or bone is having a segmental breach. That is what you call the type A injury. Type B is the one where we have the periosteum is now stripped. Okay, the periosteum is stripped. When the periosteum is stripped, what does that mean? Now this is something where we often get confused. Periosteum, how can the periosteum be damaged? Who will damage the periosteum? It is a bone itself. So when the bone is intact like this and there is a covering of periosteum onto it, if the bone comes out of the skin, what will happen to this overlying membrane? It is going to be ruptured. And that's what you call the type 3B injuries. Okay, completely open when the bone is coming out of the skin. And type 3C is the one where there is a vascular injury. When there is a vascular injury that needs repair, that needs a surgical repair. What does that mean again? The fracture shaft of humerus with the brachial artery, shaft of femur with the femoral artery, lower femur, upper tibia with the popliteal artery. These are major vessels and that definitely needs repair. Okay, so type 3, please remember the catch points from here. The catch points, type 3 has no relation with the size of the wound. It is about the damage to the soft tissues, how badly the soft tissues are damaged. Okay, that is most important here, because simple logic behind this is in GA classification, in open fractures, why we are worried? Because the risk of infection is there. Now, if the soft tissue is also severely damaged, bone is also severely damaged, that means both of them have lost the vascularity. When as a surgeon I want to operate, I can't touch this area. I have to stay here or I have to stay here. That means the indication is of an external fixator. So you can't touch any of the bone or the soft tissue area which is massively injured. That is the logic of dividing the GA classification. Okay. So yeah, before 3B, periosteum may or may not be intact. Absolutely, you are right. Absolutely, you are correct. So GA classification to be remembered for INI, for NEET, for both of them. It can be a scenario based question. It can be matching side A with side B kind of question. Right? So, or it can be treatment based question. So now you know type 3, the best indication for external fixator we have is type 3 injuries, the open or closed injury. Okay, that is Gustillo Anderson classification. What are the different treatment options? Now this is something very simple, but yet it can make n number of questions for us. What is that? what are the different treatment options we have for different injuries in orthopedics? Treatment number one is always the immobilization. Patient comes to us, patient came to me, and we just like given a plaster to him. No changes done. In what cases are we going to do that? Immobilization only. The plaster, slab, cast, where are we going to do that? Whenever there is a undisplaced fracture, right? Whenever there is a undisplaced injury. So we are going to do that. So this one is done for undisplaced injuries, right? Number two treatment option, this is undisplaced fracture. You can see a X-ray here, bone is absolutely undisplaced, nothing to be done. Don't even touch it. Send him to the plaster room and things will be taken care of. Second option we have is a close reduction and immobilization. You are just pulling the bone to bring it back into the position and then you reduce it. So now this fracture had happened, the bone has been displaced from its position, and then we are pulling, somebody's pulling from this side, somebody pulls from that side, and then you reduce it and put a plaster onto it. So what you have done, close reduction and immobilization. The commonest example we can learn from here is Coley's and Smith fracture. So if they ever ask you what is the treatment, this was your INI question. What will be the best treatment for Coley's or distal end of radius? We know that it has to be conservative. So what kind of management? What are the steps of management? It is close reduction. And how to do that close reduction? First step is always to give the traction, right? In the INI itself, they ask this. What is the first step in the management of close reduction of Coley's? The first step has to be traction, because you are supposed to align the pieces of the bone, right? So that is your traction part. Third treatment option we always have, this is a plaster given now. Third treatment option we have is close reduction and internal fixation. Now, when are you going to internally fix it? Are you able to reduce it? Yes. But after your reduction, the bone is getting displaced again because of muscle power. Definitely. So what we need to do? We have to fix them. What are we doing here? These are K wires that you can see on the screen, and this is the fixation we are going to do, right? So intramedullary nail, when you put an intramedullary nail, you can put a K wire like this, or the third option, which is often a MCQ we have, is cannulated screws. Whenever you have to put an implant without opening the fracture site is what you're calling as close reduction and internal fixation. So fracture examples, fracture of lateral condyle humerus, the common extensor is attached to it and it is going to pull it off. So once it pulls it off, you know that you may try to reduce it. I can hold it here. I'll be able to reduce it. As soon you move your fingers, common extensors are going to pull it again. So we need to fix it. So why I'm fixing it now? Because of muscular pull. So shaft of the bones, shaft, we know the periosteum, muscle is attached to it, and therefore they are going to displaced. So once the bone gets displaced, it is mandated to fix it. And without opening how to fix, only 3 implants we have. One is a nail, intramedullary nail. Second is a K wire, and third are the cannulated screws. Number fourth option we have is, these are the nails. And now one very important thing I would like to tell you here. Hi Niranjan, good evening. Good to see you here. So fourth one we have now is an intramedullary difference. How to make the difference? So always remember, orthopedic implants which are available, they're broadly made up of 2 metals. One is the steel. You can see the steel. The same color utensils we have at our home also. And other one, whenever you see the implant here, colored one, it has to be titanium. So titanium implants or the stainless steel implants we have, right? This is one. Second is how to make a difference in the femoral nail and the tibial nail. So always remember, it will never be about the length of the implant. Okay. It is never about the length of the implant. Always remember, the tibial implant, the tibial nail will always have this angulation on the top, right? This tibial nail always will have the angulation on the top, and femoral nail will always be curved. So if ever you are asked something like this in relation to the implant, you know that which one is tibial, which one is femoral. This one is shorter in height because it is a proximal femoral nail. It is a PFN. And we remember where we have to use this PFN. We are going to use it in the fractures, the outside the capsule of the proximal femur area. That is intertrochanteric injuries, basicervical neck of femur injuries. Okay, so tibial nails always have this angulation. You can see this here. You can appreciate this here. Tibial nails will always have the angulation. Femoral nail will always have that curve, right? To maintain the curve along with the femur. Okay, so this is one. Tibial is not bent. Lokesh, it is not bent. You have to call it angulation, right? This one is angulation. It is not bent. Femoral nail is curved, right? Then other treatment option we have, the next treatment option we have is, yeah, okay. So close reduction, internal fixation part is done. And now the next treatment option we have is open reduction and internal fixation. So why did you need to open the bone? Why you wanted to open the bone? Because you are not able to reduce it. And what are the fractures which are best treated by this ORIF? the shaft areas here. We have to give an incision here, we have to open the bone, and we have to fix it. So plates, right? What exactly is the difference in these two plates and this like difference? Okay, let me just tell you the difference here. What is this plate that you see on the screen? This is a traditional plate which we use in orthopedic department, and it is called as DCPs, right? It is the dynamic compression plate, right? That would be the dynamic compression plate. See, what is the other plate? What you can see, what is the difference with the other plate? The difference with the other plate here is very simple. In this particular plate, okay, right. So, okay. So the difference in these two plates is this plate has been like the pieces have been removed from here and here. Rest, there is no difference. The size of the hole, the space between the holes, the size of the plate, everything is same. Now this one where you have the extra edges, extra part of the plate removed, it is called as the low contact DCP. It is called as limited contact or low contact DCP. What is the advantage of this plate? Basically, when you're putting a plate onto the bone, the whole plate rests on the bone. Now, if you cut these areas, if you remove these areas, that means this much part is in air, not damaging the bone. So it will have less periosteal damage. So LCDCP, the limited contact DCP or the low contact DCP, they have the advantage that there is less periosteal damage. This DCP, it usually creates a lot of periosteal damage, DCP. Okay. Then we have the next option as external fixator. The questions on which have been almost in every session in the previous years. What are the different types of fixators we know? The different types of external fixators we have. So where to use them? We talked about that in type 3 open fractures. The indication is clear cut of external fixators only. All right. What are the different ones we have available? The first one that you see on the screen, it is the Elizaro, right? We all have been reading it in the final years in your wards. This is one of the okay, so no, laptop is not on charging. Thank you so much, Rakesh, for putting that on notice. That is not on charging. Once I take a break, I'll shift onto the pad instead of this laptop. So it is creating some trouble. I can see that. Okay, so this one is Elizaro, and you all can appreciate, like you all know about the Elizaro. The second one that you can see on the screen is LRS, the limb reconstruction system, or what you call as rail fixator. Now, this was your INI 2020 image-based question, right? So LRS, the limb reconstruction or the rail fixator here, the second one. The first one is Elizaro. This one is LRS, the limb reconstruction system. And then we have the third one. These are the most commonly, or you can say the easily available implants in the orthopedic OT. The cheapest one and the easiest one to apply, right? These are called simply the rods and clamps. The rods and clamps, the number third. Okay. So these are three most commonly used external fixators here. Now in the previous years, how the questions have been asked, first time in the 2020 when they asked the question, it was simply an image-based question. This LRS was your MCQ, INA exam. Next time, they gave you another like theoretical question where they asked it, which one of the given external fixator is having maximal stability, right? So which one? The options were a uniaxial single rod and clamp. Uniaxial single rod and clamp. What does that mean? When you look at this bone tibia, there is one rod which is parallel to this broadly. So uniaxial, one axis of the tibia. So uniaxial single rod, uniaxial if you put double rods, right? Uniaxial double rods. Then they said multi-axial, like this particular image is multi-axial. Fourth option was Elizaro. Now you can very well appreciate here that Elizaro is giving you the stability from all around, right? It is giving you stability from all around. So that is supposed to be the highest or highly stable external fixator. After that will be multi-axial rod and clamp. After that will be the simple side or single side, you have double rods, and then you have single rod on single side, right? So this was the second time. Third time, they gave you one image. This is how behind me, you can see the external fixator being applied. Third time, they gave you one image where they asked you something like this. The fixator was applied in femur. One of the fixator was applied in femur. Okay. And yeah. So one of the fixator was applied in the femur. It was like this. What's wrong? There's something wrong. Second fixator was there in the tibial part as well. So one fixator here, one fixator here. And then at the end, what they did, they connected these two fixators. They connected these two fixators and they asked it that why the fixator has been applied. So when a fixator is there in femur, when another one is in tibia, and then there is an interconnecting rod, it simply means that you are trying to distract the joint because there has been a periarticular injury. So that was the third question they asked, like what is the purpose of this fixator? All right. Now these are the different fixators and treatment options. So we have done 5 options: immobilization only, close reduction immobilization, close reduction internal fixation, open reduction, internal fixation, and external fixation. These are 5 options we have to treat any of the trauma patients. Then when you talk about the polytrauma, yeah, spanning, you are right, Bias. Spanning is when you are putting a fixator which is around the joint area. That is a spanning fixator. Then we have the neurological assessment of the patient post-trauma, and we call it the Glasgow Coma Scale. You all know that it is always about the eye opening, the best motor, and the best verbal response of the patient. Scoring system, you have to remember, in the NEET exam 2018, they asked you a question that a patient is presenting in emergency when the eye opening is on painful stimulus. So eye opening on painful stimulus gives it a score of 2. Then they said the patient is confused. If the patient is confused, we go with the scoring of 4. But then there were 2 scenarios given to us. One was the patient is pointing to the site of pain from right side, and there is a flexion withdrawal from left side. Pointing to the site of pain from right side, that makes it a score of 5. Flexion withdrawal on left side, what score should I take? So now that goes with the score of 5 only. Always remember, you have to go with the best score or the better score, right? That is your Glasgow Coma Scale. It is not only EVM, it has to be the best EVM. Whatever is the best scoring given, whatever is the best score patient shows you, it has to go like that. Okay. Then we have the next one, the shoulder area. Let's start with the trauma, upper limb, the injuries. These were all the basic points about the trauma. So in the shoulder, what all are we supposed to remember in the shoulder area? So remember that there are, in the shoulder, the questions in your exam, they can be asked in multiple ways. The 2 most important things that you always have to remember is, at any trauma site, any upper limb, spine, lower limb, at any trauma site, if a particular muscle or the nerve supplying the muscle, if it is affected, then that is going to restrict what movement. That is going to create what kind of clinical presentation of the patient. So presentation of the patient is going to be the most important thing when you're talking about the trauma cases, right? Now, let me give you certain examples and let's see how different topics can be sorted from this single table itself. How? If in your exams, they are telling you that the patient is coming to you with complaint of pain around shoulder and he's not able to initiate the abduction. What does that mean? You know that initiation of abduction is done by supraspinatus, right? Initiation of abduction will be done by supraspinatus, right? If the patient is being told that, you're being told in the history that patient can't do initiation even, that means supraspinatus is gone. And it can only happen because of 2 reasons. One, it is either a complete tear of the supraspinatus or there is a palsy of the supraspinatus which is supplied by which nerve? Suprascapular nerve, right? That is by suprascapular nerve. Number 1. Second, your exam question tells you or your OPD patient tells you, sir, initiation is okay, I can do it. Initiation is fine, I can do it. But after initiation, there is some difficulty and I cannot do. I have to support my hand till here and now I can do that further. What does that mean? Abduction failure at 50 to 90 degrees. Which muscle is responsible? It is a deltoid. And if it is deltoid, there can be only again 2 possibilities, that it is torn, deltoid is ruptured, which happens in very less number of cases, but then more commonest will be the nerve palsy, that is the axillary nerve injury. Axillary nerve injury is very, very important here, and that will have multiple other presentations as well. So please remember, when axillary, you're talking about that, axillary nerve is the most commonest nerve involved in proximal humeral area. Whether we are talking about the dislocations of the shoulder, please remember this point. In the dislocations of the shoulder, axillary nerve is the most commonest nerve to get involved, and when axillary is gone, it supplies 2 major muscles. One is deltoid and other one will be teres minor. So what is the problem to the patient? Patient can't do abduction 15 to 90. Second, there will be weakness in the external rotation of the shoulder. There is weakness in external rotation of the shoulder, right? That is another one. So axillary nerve is the most commonest acute complication. Please mind this word. This is the most commonest acute complication of the shoulder injury. Most commonest acute complication. When in your exams, this was a very recent session question of INI 23. They asked it, Bankart lesion is seen where? So please remember, shoulder topics are very, very important. Okay. So there are 2 important things when we are talking about the shoulder dislocation. One, number 1 is all about that what is the most commonest complication overall. Most commonest complication overall is recurrence. Most commonest complication overall will be recurrence. Most commonest acute complication has to be axillary nerve injury. And if axillary is damaged, there will be a problem to deltoid 15 to 90 and there will be a problem to teres minor, that is external rotation goes weak. It is not lost, it is weak. Why? because for external rotation, we have another muscle as well, that is infraspinatus, which is supplied by suprascapular nerve. Okay. Second is the loss of sensation on this area. That is a regimental badge sign. That is a regimental badge sign. All right. So 15 to 90 deltoid. Patient tells you the third and the most commonest question in our routine life and in your exams. Patient is able to do abduction, but pain is there in mid-range. NEET exam 2018, it was a definition based question, and n number of time it has been asked in the previously conducted PGI or the All Indias, the AIM, sorry. Okay. So pain during 60 to 120 degrees of abduction. Patient starting with abduction, no pain, and now the pain starts. It is all painful, and now the pain disappears. Pain during mid-range of abduction, that is painful arc. What is the other name for this? We call it impingement syndrome. So what can be the pathology your patient might be suffering from? The impingement syndrome, the painful arc, or the impingement syndrome. So please remember, it is about supraspinatus now, right? That is about supraspinatus now, which is having what? Partial tear. So read carefully your questions. If it is a complete tear of supraspinatus, there will be no abduction at all. But if it is a partial tear of supraspinatus, it will have a pain between 60 to 120 degrees, right? That's a very logical thing, and you don't have to mess that up in your exams. If they ask you complete tear, sir, no abduction. A partial tear, what will happen? When the arm is being abducted, the supraspinatus will go under the acromion and there will be impingement here. That is why we call it an impingement syndrome. So pain starts at 60 and ends at 120. That is classical one. So all the three are your MCQs for the exams. Very important ones. All right. That is in shoulder. Further, in the shoulder, what else? See, there are two things. One, I told you, what if your exam question is saying there is a difficulty in movement? What if the exam question is telling you difficulty in movement? Second, what if now the exam question tells you that there is a difficulty in mobility at other areas? For example, very, very important one, the problem with the internal rotation. Internal rotation, how do we do that? Internal rotation, if I keep my arm neutral, this is my neutral shoulder. Follow this, the forearm here, it is a pointer now, and this pointer, when I turn it out, it is the external rotation of my shoulder. When I move it in, it is an internal rotation at my shoulder. So now if somebody is having a trouble in internal rotation, what is the best way to test it? Ask the patient to keep the hand on the lower back, right? Ask the patient to keep the hand on lower back. That is my terminal internal rotation. What is the classical clinical test we do to check for the strength of this internal rotation? The classical test is ask the patient to keep the hand on lower back, and by your other hand, you just keep your hand on the patient's back. Now ask him to lift it against some resistance, right? This is what we are calling as the lift off test. I hope you remember, and we are doing it for what? The subscap, the lift off test, right? That is the lift off test. All right, that will be the lift off test. So if somebody, now the question of your exam, if somebody comes to you in your OPD and this straightforward asks you the question two ways, the OPD patient or the straightforward, what is the first movement lost in adhesive capsulitis? What is the first movement which will be lost in adhesive capsulitis? What do you suggest? Adhesive capsulitis, there are three terms. Now recall your orthopedic part. There are three terms: adhesive capsulitis, frozen shoulder, and periarthritis of the shoulder. Frozen shoulder, periarthritis, they will be sequelae of adhesive capsulitis only. Adhesive capsulitis, adhesion in the capsule because of itis, inflammation. So capsule is getting inflamed here, and next to the capsule in the front of scapula, anterior surface of scapula, we have what? The subscap. So when it is inflamed, the person will have the trouble in putting the hand on the lower back. Look at this video now. So if you look at this video, the lady is trying to mobilize the shoulder in front. She's going till 90, 100. That's okay. She's trying to abduct. Now see what happens to her. When she is going in abduction, what happens there? She's going well till 90 or 100. When you ask her, like, just have a focus on her head also. We have hide the face. And now she's putting the hand on the lower back and she gives up. We insisted that you should try. She's trying here and then she's nodding her head. No, not beyond that. First movement lost in adhesive capsulitis always and always is internal rotation. I'm not saying it is lost. I'm saying patient will resist it. Patient will try not to do that. And that is your internal rotation. All right. Second, whenever there will be a tear, I've told you, whenever there is an injury to the subscap, it has to be the lift off test which is to be done. Then, if the patient is telling you that I'm having trouble with the external rotation, question says the patient is having difficulty in the external rotation, we know what we are talking about. Two muscles, both supplied by different nerve. Teres minor if it is axillary problem, infraspinatus if it is subscapularis, right? So difficulty in movement in your exams, in your question, they are pointing to a particular pathology. Be very, very vigilant with that. Second one, the second part of the same thing. Okay. In first one, we have talked about that what if, second one, we are talking about now, what if the patient is presenting with a particular attitude, right? Patient's presentation, let's suppose it is abduction and external rotation. How is that? Abduction, away, external rotation, like this. It comes up in what kind of pathology? This comes up in anterior dislocation of the shoulder. We know anterior dislocation is the most commonest dislocation of the shoulder, and in the anterior dislocation, which is the most commonest variant here, it is a subcoracoid. It will be the subcoracoid. When the head of humerus, it lies below this coracoid area, that is subcoracoid, right? Second one, when you talk about, there are 4 important points you must remember about both the dislocations. 4 important points about both the dislocations. Number 1, attitude. It has to be abduction and external rotation. Number 1. Number 2, the most commonest type of dislocation, anterior dislocation, is subcoracoid. Number 3, your comments on contour of the shoulder, this contour of the shoulder, how it will be? Will it be lost or will it be maintained? So always and always, it is a rule that in anterior dislocation, it has to be lost. It can't be present. See this fellow. So now if you appreciate here, the contour is lost absolutely, and you can see a bony prominence there. What is that prominence? Trace your clavicle, you go laterally, and on the lateral aspect of shoulder, you can see this, the prominence here. What is that? Acromion, right? So contour has to be lost. And what is the way to reduce anterior dislocation? It has to be Cocker's method. What is it, Cocker's? Traction, external rotation, adduction, and medial rotation. So traction, give traction, go for external rotation, go for adduction, and go for internal rotation. That is going to reduce the shoulder, right? 4 points about the posterior dislocation. Okay, 4 points. How does the posterior dislocation happens or presents to us in the emergencies? It is adducted arm and interrotated arm. Adducted and internally rotated arm. Common in which categories of patients? This posterior dislocation is very, very common in the patients of epilepsy and electric shock, right? Epilepsy and electric shock. Why? Again, the electrical impulse in the body, it will make the muscles and the fascias and capsule, everything get contracted. When they contract, this head of humerus has to turn in, and in front we have the subscap again. So it is not allowing the head of humerus to go back. So patient will be keeping the hand like this. Very important point is the contour of the shoulder will be maintained, right? Anterior dislocation, the contour is lost. Posterior dislocation, it is usually maintained, and that is how we get confused. So in your exams, if you are getting a patient who is taking phenytoin, who is taking phenobarbital for last some time, today morning he fell down, or a person who was working on some electrical plug or a pole, he got an electric shock and he fell down. And after that, once the patient is okay, stable, he is not able to mobilize his shoulder, but contour is maintained. Please note, it is going in favor of posterior dislocation only, right? So contour will be maintained. So what are the 4 points here? 3 I told you. Adduction, internal rotation, electricity, this shock or epilepsy patients. Number 3, contour of the shoulder has to be okay. Number 4, how is that seen on x-rays? On x-ray, if you see my right shoulder, my right glenoid, my right head of humerus, so it is how the shoulder is. Now when it turns in, this is what you see. Instead of anterior surface, what you are able to watch is the lateral surface, which is little wider here, which appears like what? If you can tell me that. They appears like what? They will be appearing like the upper end of a electrical bulb. So what do we call that? The lighthouse sign or the electrical bulb sign, right? So 4 points, yes. Satya is going very, very quick. Avatar is very, very quick. Perfect, guys. So good to see you all are so actively participating here. Wonderful. Super proud of all of you. Wonderful. Okay. So shoulders presentation or shoulders restriction, that will be the key to reach to some diagnosis in your exams, in your OPDs. Okay. Be watchful about these words. So 4 words on both the things. And now this is what you're calling as electrical bulb. Look at this. Head of humerus, you can see rotated internally. So this is electrical bulb sign. Second step of this will be when the head of humerus goes absolutely away from it. So this head of humerus goes out. So this glenoid is now empty. Nothing is articulating with it. What do we call that? Empty glenoid sign. Okay. So shoulder will be very important area, and definitely you can expect some question from here in some form for sure. Okay. So presentation diagnosis, I have summarized in all. These are the, okay. Now the second important part I told you is after the shoulder, at what all sites, what all nerves can be involved, and if a particular nerve is involved, what will be the presentation of the patient. How do we go ahead with that? Okay, so let's see those. Again, this is just a table where all the important nerves, all the important injuries are mentioned. So let's start from the top. Okay, and let's start from the top. Number one, when I start from the hand area, you know very well that in the hand area we have got these 8 carpals here, and on the ulnar aspect between the pisiform and the hamate, we have this area called as Guyon's canal. And what is passing from here? That is the site of which nerve? We all know that it is a site of ulnar nerve. So ulnar nerve passing here under this the branch of the ulnar nerve passing. All right. So ulnar nerve passing under this, the digital branch of the ulnar nerve is this Guyon's canal. That is the ulnar nerve. Second is a carpal tunnel syndrome. We know that carpal tunnel syndrome is compression of what? The median nerve here in the carpal tunnel. What can be the reasons here? Reason can be anything which narrows the space here, like some fractures, fracture of the scaphoid, the dislocation of the lunate, the Colles injury. These all can compress upon the median nerve. Pronator syndrome, when there is a compression of median nerve in the forearm area under pronator teres. Then we have the Monteggia fracture. Where is that? Fracture of proximal 1/3 of ulna, fracture of proximal 1/3 of ulna with dislocation of the radial head. And you know that around the radial head, which nerve is there? It is your radial nerve, right? So radial nerve's branch is there, that is posterior interosseous nerve. So in case of Monteggia, please note that this can be a very important MCQ for the exams. In Monteggia fracture, which nerve is involved? It is the PIN. And if the PIN is involved, you know very well that what will be the presentation of patient? The wrist will be all right. The wrist will be all right. It will only affect the fingers. So patient will be able to extend his wrist. Patient will be able to extend his wrist, but fingers will be drooping down. So finger drop is the presentation that we see when there is a Monteggia. How we get confused in the exam? The fracture is happening on medial side, right? Monteggia, the medial bone, proximal 1/3 of ulna. Fracture is happening on medial side, but nerve is getting involved on lateral side, right? So patient's extension, the presentation will be very important. So be very calm and cool in your exams. Don't just get panicked that if it is only about the wrist extension, it has to be radial. True. Fracture always doesn't have to be the humeral shaft, right? So Monteggia. Second important area is the humerus lateral condyle here, right? Second important area is the humerus lateral condyle here. Whenever you know that lateral condyle is injured, the common extensor is attached to it. And the most commonest complication we know, if lateral condyle is not treated on time, is non-union, right? That is again very, very important. So there will be non-union. And if there is non-union, with the growth, what happens? With the growth, what happens? When there is non-union here, there will be gradual forearm deviation into the lateral aspect. So when forearm starts going laterally, what is the deformity we call it? What is the deformity called as? That deformity is cubitus valgus. Now the forearm is going laterally. So that will be cubitus valgus. Now when it goes into valgus, what happens? There will be stretch on all the medial side structures here. There is stretch on all the medial side structures here. And most important structure we have under the medial epicondyle is the ulnar nerve. So this is why we are calling it tardy ulnar nerve palsy. That is a late involvement of ulnar nerve. Please remember, please write down, please highlight. These are two most important sites, right, which are crossed, and often we get them wrong in the exams. So fracture of medial side, Monteggia, affects the lateral side nerve. Fracture of lateral side, it involves in late stages, late time, the ulnar nerve, right? After a long part of injury, maybe 6 months, year, 2 year, like that. That is tardy ulnar nerve palsy. Medial condylar injury, direct impact will be on the ulnar nerve, nothing special in that. Then supracondylus, very, very important again. When you talk about the supracondylar injuries, you know that supracondylar fracture are metaphyseal fractures, and this is usually a closed area. Now, if the injury is happening in a closed area, in this particular closed area, and the space is getting compromised, what will happen then? That compromise of the space will produce the edema into the distal part. And the median nerve, why we are calling it median, being in middle part of the arm area. So when you look at this median nerve, just below the elbow, the median is giving you a nerve, a branch which runs very superficially in front of the interosseous membrane. And that is why we are calling it what? The anterior interosseous nerve. So just below the elbow, median nerve is giving the AIN, and that AIN is getting or gets most commonly involved in every supracondylar fracture. How is that possible? Injury is here, nerve is here. As I said, it is all because of edema effects, right? The edema that happens, the rise in the pressure that happens. AIN. Now, this AIN, how do you check it? AIN, you know, is supplying two major muscles. One is flexor pollicis longus. Okay, one is flexor pollicis longus. I hope that you are writing also side by side the flexor pollicis longus and flexor digitorum profundus. Flexor pollicis longus and flexor digitorum profundus. So how do we test it? Ask the patient to flex both of them. If the patient can make a okay, AIN is okay. So first thing I would like to see in any of my supracondylar case is the flexion of these two. That is the okay sign. What we call that? The okay sign or the Kilonevin sign. The okay sign or the Kilonevin sign. Shaft of humerus, you know very well that most commonly involved nerve has to be the radial nerve, right? Proximal humerus, it has to be axillary. We have discussed that regimental batch sign, deltoid and teres minor. Clavicle, another very, very important area. See, under the clavicle, usually there is no neurovascular compromise, usually, but sometimes it can be a part of thoracic outlet syndrome. Thoracic outlet syndrome, it can be of two types, right? What is a thoracic outlet syndrome? In the front, we have the clavicle, or maybe sometime the extra rib, that is a cervical rib. And beneath that, there is a scalene muscle, usually the medius one. So between the scalene muscle and the cervical rib, there is a neurovascular structure going. One is the brachial plexus, one is the subclavian vessel. So when there is a compression of lower trunk of brachial plexus, we call it the neurogenic thoracic outlet syndrome. It is called as neurogenic thoracic outlet syndrome. And whenever there is a compression of the subclavian vessel under this, we are going to call it the vasculogenic thoracic outlet syndrome. Vasculogenic means the subclavian vessels. That is the subclavian vessels. Okay. And in relation to the subclavian vessel, we have got certain clinical test also. I'm just going to discuss them with you in a while. Right. Then when we have a patient of trauma, the posterior dislocation of the hip, for which we know that the mechanism described has been usually dashboard. So dashboard means when you're sitting on the car or in the front seat of the car or on your chair right now, hip and knee flexed, if there is an impact onto your knee, what will happen? That impact onto the knee goes to your thigh, thigh to the neck of the femur, neck to the head of femur, head to the socket, and it perforates the socket, goes back. That is what we call dashboard. So that most commonly involves sciatic nerve. So if the sciatic is involved, if the sciatic nerve is involved, what will be the presentation of the patient? That is a flail lower limb, foot drop simply. In the recently conducted INA exam, the November session, they asked about it. What will be the gait of the patient if there is a foot drop? So what is the gait of the patient if there is a foot drop? He is lifting his foot and it falls down. He tries to lift his limb and the foot falls down. Foot drop. So it has to be a high stepping gait, right? It has to be a high stepping gait. Okay. Inguinal ligament, lateral cutaneous nerve of thigh. We know that. And that entity is called as what? What is the fancy name given to this? It is called as meralgia parasitica, right? That is called as meralgia parasitica. Okay. Meralgia parasitica. Then we have proximal fibula. That will be common peroneal nerve, right? Same sciatic, the foot drop. CPN also will have foot drop. Posterior dislocation in dashboard. Yes, it is a posterior dislocation in dashboard. Absolutely. And then we have tarsal tunnel. So the sciatic nerve divides in the thigh into two branches, major two branches. One is a tibial nerve, one is a peroneal nerve. Peroneal is for the fibula. Okay. So tibial nerves, when they get entrapped in the tarsal area, right? That is what you call tarsal tunnel syndrome. In the tarsal tunnel area, it is a tibial nerves. Morton's metatarsalgia is the last entity. That is a compression of digital nerves under the toes. Compression of digital nerves under the toes. Okay. So that is like, these are the different areas where particular nerves can be involved. The sites and the nerve involved. Okay. I hope this table is clear. All right. Okay, fine. So this is correct. Absolutely right. So let's move on to the next one. Let's see the next one. What do we have? So Guyon's canal, ulnar nerve, carpal tunnel. We have shown you pronator here, the pronator teres, Montegia, usually the PIN, the humerus lateral condyle, tardy ulnar nerve palsy, late involvement of ulnar nerve, and the medial condyle, direct impact onto the ulnar nerve. That is how it happens. All right. So this one, supracondylar fracture AIN, the edema effect, not the direct trauma effect. It is an edema effect, stretch effect basically. Proximal humerus, axillary nerve, clavicle here, the thoracic outlet syndrome or the lower trunk of brachial plexus, subclavian vessels, all can be involved, and shaft of humerus, radial nerve, and then this is an inguinal ligament, lateral cutaneous nerve of thigh. This one, the posterior dislocation, dashboard. Yes, it is a dashboard. Perfect. Okay. Proximal fibula, it is a common peroneal nerve, and in fact, this has been an image-based question in the year 2023. This question has been asked 3 times, right? All the 3 exams it has been there. Tarsal tunnel, the tibial nerves, and then Morton's metatarsalgia, it has been digital nerves. All right. So these are different areas. I hope we are fine. We are on the same track. Everybody's on the same page. Everyone is good to go. Shall we go the same way? So let's see what you have to respond to this. Let me even open up my, yeah. Oh, so good to see so many here. The one shot revision. Oh my God. So good to see you guys. So yeah. All right. All right. Yes, perfect. Perfect. Let's go ahead. Perfect. So this is now the next part. Now, when you're talking about the nerves, please do remember nerves, they have got a question the presentation of the patient is very important thing, no doubt in that. Second question that comes from the nerve side is about the kind of injury the nerve may be having. And after the nerve is injured, how do you manage it, by what particular kind of splint? So clinical test for the nerve, splints for the nerve, classifications for the nerve, from everywhere we get some questions, right? Now, if I tell you something very, very basic, very, very quickly here, that structure of the nerve, when you look at the structure of nerve, the outermost layer of the nerve, what do we call that? The outermost covering of the nerve layer is epineurium. That epi has got multiple bundles inside them, right? The bundles are inside them and they are called as what? The fascicles. What is the covering of those fascicles? That is called as perineurium. So this bundle, this is what you call perineurium. And what is that perineurium carries? It carries the bundles of axons, multiple axon. And we know that this axon is the functional unit of the nerve. Axonal covering is called as what? Axonal covering is called as what? The endoneurium. So outermost is endo. Then we have the fascicular bundle, which is like peri, and outermost layer overall, it is the epineurium. So when you see the classification of the nerve injuries, we have got two. One is sedens. One is sedens. Just focus here on this part of the table, the sedens. And second one is Sutherland. Focus on the sedens. Sedens classification, is of three types. One is neuropraxia. That is a physiological conduction block. Okay, that is usually just a physiological conduction block. Commonest example we know, when you sit cross-leg. When you are sitting one leg over the other leg, your upper leg becomes numb sometime. No? When you relieve the pressure, the leg is okay. It is absolutely fine. Does that mean your nerve is injured? Not exactly. It is just a pressure effect. Another, the best example we can learn for the neuropraxia, it is the Saturday night palsy. Usually the Saturday night palsies are neuropraxias. Usually the birth-related herbs palsies are neuropraxias. So they usually, that is the reason why they recover most of the time and they don't require a surgery. Okay. Second grade of injury is what you call as axontomesis. So if this axon is getting involved, that means its covering may be getting involved, maybe may not be, right? So axontomesis may involve the endo, may not involve the endo. So this is the real grade of injury in the peripheral nerves. So when you talk about the MCQs in the previous years, how they have asked it, year 2019 AIMS and 21 INI set, they've asked this question, grade the nerve injury when the nerve is injured but the sheet is intact. So nerve is injured only in axontomesis, not in neuropraxia. So if there is an injury to the axon, the outermost covering or the covering of axon actually can be spared. Third grade of injury is neurotomesis. Third grade of injury, it has to be neurotomesis. What is that? Complete cut of the nerve. So when the nerve is cut, I have to go for a surgical repair. I've got no other option left, right? So neuropraxia, axontomesis and neurotomesis. Axontomesis has been a question in the previous years, right? Sutherland, it caters or it covers up the grades based on the sheets involved, whether it is epi only, peri also, endo also, what is getting involved. So most important, I would say, is sedens, right? That should be very, very clear. Yeah, I'm coming on to that. Now, these are different splintages that you should be knowing from the nerve section. You should know them very, very well. What is happening in the very first splint, what we are doing, if I label this as a first splint, A splint here, you can see that the knuckles here are being bent. And knuckles are being bent for what? To keep the fingers extended. Why I am bending my knuckles to extend my fingers? Because they were in the opposite posture like this. And where do we use that? That is being used whenever the patient will be suffering from claw hand, right? Will be used whenever the patient will be suffering from claw hand, complete claw hand, ulnar claw hand, or the mixed claw hand, basically we call it. So claw hand, what is that splint called as? This one, first one is knuckle bender splint, right? Knuckle bender splint. Second problem that you can see is the fellow is having the wrist which has fallen down like this. Now, if the wrist is falling down, if you don't just elevate it, this area may develop contraction. The muscle might be getting wasted. So what we do, we give them the splints which can keep the wrist extended like that, right? And this one is what you call as now the cock-up splint. This one is now what you call as the cock-up splint, keeping the wrist in extended position. Now look at the difference in these two splints. Both are used for the wrist drop only. What is the basic difference? If you look at this number 1 splint, it is keeping the wrist in a stagnant position like this. But if you look at the other one, there is a spring connected to it, right? Why there is a need for a spring mechanism? So that it can dynamize, so that it can mobilize, right? The patient is having a difficulty in flexion. Basically, the patient cannot do the extension, so he's having the limb flexed. Splint is going to take it back, and now you ask the patient to flex it, right? The splint takes it back, you ask him to flex it like this. Okay, so the knuckle bender splint or the other splints, any splint you may name, there are of two types. One is static. The first one on the up screen is static one. Second one is what you call as the dynamic one. Static one or the dynamic one. This has been a specific question of your INSET exam where they categorically asked it whether it is a static splint or a dynamic splint, right? Whether it is a static splint or a dynamic splint, right? So please be very, very aware of this thing. Whenever there is a mobility, it has to be a dynamic splint. When it is a fixed state of the hand or the limb, it has to be a static splint. All right. Then we have different splints which are used in different injuries. Let's talk about that as well. Where do we use Thomas splint? You all have seen Thomas. Let me just show you all these splints. So this one that you see on the screen is the Thomas splint. You know where to use that? It is for the fracture shaft of the femur, right? That is used for the fracture shaft of the femur, right? That is for fracture shaft of femur. So there is a ring on the topmost part, and this ring is never parallel to the ground. It is little inclined, right? How much? When you see the angle, okay. Just give me a moment, please. Okay. All right. So this one, the splint here. So when you look at this, the angle between this ring and the inner bar, it has to be close to 120 degrees so that it mimics the angle that we have in the groin area. Then we have a sharp angulation here that tells us that this is the lateral aspect of the Thomas splint. Why? This is given here to accommodate the greater trochanter. Okay, that is Thomas splint. The second one that you can see is what you call as mermaid splint. Mermaid is given in the legs area. Why? For the kids who are having the genu varus or the genu valgus deformity, like that. Okay, so genu varus or the valgus deformity. This is mermaid. Number 3 that you can see this boy wearing, and you can appreciate the back of the child. It is having some curve on the back, right? To correct this curve, what we are doing, putting a pressure onto the chin, pubic area, occiput area, iliac area, and as the child will keep on growing, will keep on increasing the traction like this and like this and like this and like this, like that more, right? So this is what you are calling as the Milwaukee brace, right? This is the Milwaukee's. Milwaukee typically being used for the scoliotic curve of the kids. Then we have this one, the hand of the patient being kept like that, so that there is no contracture, muscle wasting on all these areas, right? This is what you're like looking like what? The wing of an aeroplane. So we call it simply the aeroplane splint. Where to use it? The brachial plexus injuries, the upper roots usually. Okay. And then we have these splints which are given to the kids, the newborn babies who are having the deformities in their foot, the CTVs, right? What do we call that? The Dennis Brown splint. Yeah, this is the Dennis Brown splint. Okay, how do I differentiate between the knuckle bender splint, dynamic and cock-up? Oh, come on. I have given you such a clear picture. Okay, so I've just shown you clear picture how to differentiate. See this? There is a lot of differentiation. Keeping the whole wrist extended is keeping it elevated, cock-up, and bending the knuckles to get the length for fingers. Knuckles are not bent here, no? Knuckles are not bent here. So knuckle bender, the knuckle will be bent. Okay, that is how you differentiate. Right, so yes, you all are right, absolutely correct. It has to be these splints. Okay, I'm sure you are not going to mark it wrong if they ask you theoretically, or they may ask you like in other way as well. All right, now this one, coming on to this picture, this is what we are doing for the vasculogenic thoracic outlet syndrome. What is this test? If somebody can say, what is this test? What the person is trying to do? Elevating his hand like this. What is he doing? So another one is like this, Adson test and the Roos test. So why are we doing it? I told you that the thoracic outlet syndrome, it can be vasculogenic as well, right? So subclavian compression. So what are we doing here? Number 1 is the Roos test, right? Roos test. How to do that? Ask the patient to abduct and extend the arm, the shoulder a little bit, and keep on opening and closing the fingers like this, right? So pulse will become feeble on the side. There is a compression. That is one. Roos. Second one is what you call as the you can say Adson test, right? Adson test is what? You just feel the pulse. Ask the patient to extend the neck and rotate to the side. You are checking like this. That is going to compress the vessel again. Third is the right this is a right, and what you do in the right test, you just elevate the limb of the patient like this, right? That will be the right test. Okay, so raw, this is what you have to do as raw. All right. Okay. Not viewing the screen, I'm unable to understand what that means. All right, so these are the clinical tests which are to be done. Let's have a look on the clinical test. Every exam, you start from 18 till date, every exam had one question on the clinical test, right? Let's have a look on every test as well. So trauma will be a section where most of the things are actually covered up. Okay, so list of the clinical test, let's talk about that as well. So carpal tunnel syndrome, what are we looking for in the carpal tunnel? We said we are talking about the compression of median nerve. So very important questions have been coming from here in your previous year INI set or the NEET exam as well. So carpal tunnel syndrome, when you look at that, carpal tunnel syndrome is the compression of the median nerve, isn't it? It is a compression of median nerve at the carpal tunnel area, the flexor retinaculum here. Okay, what is the first question? What is the most sensitive test which can be done? What is the most sensitive test for carpal tunnel syndrome? The most sensitive test is Durkin. What is a Durkin? Directly compressing upon the median nerve. Directly compressing upon the medial nerve. It is a Durkin's test. Phalen's test. Phalen's test is what? Phalen is when you keep the hand of the patient like this, and that is a Phalen's test. Right? Compression upon the course of the nerve. That is Phalen's. Okay. What do you also call it as? Reverse prayer sign. Third one is tourniquet. What is that? Apply the BP curve and raise the mercury column. Because of venous engorgement, there would be pain. And Tinel is tapping on the course of the nerve. So Durkin has been your INI set exam question of 2020, I think, or 21. One of the year they asked it. Durkin's test, the most sensitive test. Decurvains. What is that? You know, decurvains is an inflammation of abductor pollicis longus, and extensor pollicis brevis. Abductor pollicis longus and extensor pollicis brevis. Where are they? When you look at your hand, the first belly that you see, the first extensor compartment here, that is your APL and EPB, right? That will be the APL and EPB. So abductor pollicis longus and extensor pollicis brevis, when they get inflamed, what are the clinical tests you should know? Finkelstein or Eickhoff. Finkelstein test or the Eickhoff test. What is that Finkelstein or Eickhoff? Eickhoff is you ask the patient to keep the thumb in the fist, step 1, and go for ulnar deviation, right? Thumb here, ulnar deviation. This is Eickhoff, which we traditionally have been reading as Finkelstein. But what is the exact Finkelstein? Just pull the thumb. When you just pull the thumb, it is going to create some tenderness effect here, the pain effect here. That is Finkelstein. Tennis elbow, the lateral epicondylitis. What is that? Again, the common extensor getting inflamed. And what is the test to be done? Flex the elbow, ask the patient to extend the wrist against some resistance like this. This is what you call the Cozen test. Subscapularis. Ask the patient to keep the hand on lower back. We discussed that point. And examiner is going to stop it somehow and ask to lift it against some resistance. Now that is what you are calling as lift off test. Empty cane test, the supraspinatus, one of the most important superficial muscle of the rotator cuff area. Supraspinatus, the empty cane test. How? Ask the patient to just, flex the shoulder, keep it like this, and against some resistance, ask him to just lift it as if you are emptying some can. That is empty cane test. Anterior dislocation of the shoulder here. What are the clinical tests to be done? Dugas test is number 1. What is the Dugas test? Patient can't touch the opposite shoulder. Patient won't be able to touch the opposite shoulder. Why? Because the head of humerus is already out anteriorly. That is Dugas. What is Hamilton ruler? When you put a scale onto the lateral aspect of shoulder, it is going to either come onto my neck side or obliquely like that. It doesn't go towards my elbow. But when there is a dislocation, the acromion and the lateral condyle can be touched at the same time. Right? That is Hamilton ruler. What is Cave? Cave is increase in the axillary circumference because of the stretch effect onto the anterior axillary fold, right? The thoracic outlet we have just seen, we have just discussed. Satya, I'm not sure about what you are asking. If both the options are there, I think you are asking about Finkelstein, go with the Eickhoff. If you're asking about this, go with the Eickhoff, okay? Then we have scoliosis, Adams test. What is that? Adams test is done to assess the difference in the postural scoliosis versus the pathological one. If a child is growing too abruptly, right, certain growth spurts are there, or if an adult is there who is too tall, there might be some curve which can be appreciated on their back, right? How to differentiate it is real pathological one or no? Ask the patient to stand straight and bend forward. When they flex forward, the postural one, which is actually not there, it will be hidden. It will be obsolete. Okay, pathological one is going to persist. Ankylosing spondylitis, a very important topic for your exams, and almost like 3 times it has been asked in the recent year as well, right? So ankylosing spondylitis, what are the clinical tests to be done? The modified Schauber's test. Again, you check for the restriction of lumbar spine. Gansilin and pump handle behind me. The gansilin and pump handle, why are we doing it? They are being done for sacroiliac joint, right? We do them for what? Sacroiliac joint. All right. Thomas, one of the very, very important and repeated question of your recent year exams, the Thomas test. Why are we doing it, Thomas? In fact, if you recall, in the year 22, they have asked it as a sequential arrangement kind of question. They have given you certain steps and you are supposed to arrange them in a sequence, right? So fixed flexion deformity of the hip, it is being tested by Thomas test. I hope you all are aware of this, the Thomas test. So cruciate ligaments, you know that it has to be anterior drawer, posterior drawer, or specifically for this drawer, you know that drawer has to be done with how much flexion of the knee? When you pull the tibia anteriorly and you push it back, that has to be the drawer at 90 degrees of knee flexion. But then we have another test which can be done in acute cases. Which one? For ACL acute cases. For ACL acute cases, what is the test we have? It is Lashman. It is the Lashman. Okay, that would be Lashman. Then we have the menisci test, the meniscus. Most importantly, we have McMurray's and the Epley's grinding test. The McMurray's test or the Epley's grinding test. All right. For tendo-Achilles, for checking for the integrity of the tendo-Achilles, is the tendo-Achilles tendon perfectly fine or no? So what we do is a Thompson test. You ask the patient to lie prone and you squeeze his calf area, right? So when the patient is lying prone like this, the hip, the knee, the leg here, so you just squeeze his calf area. Now, you know that gastrocsoleus complex is making the tendo-Achilles here. When you squeeze the calf, what will happen? The foot goes down like this in the plantar flexion. Now, if it is going down, it means the integrity is there. The tendon is all right. The tendon is fine. But if the tendon by chance is cut, there will be no mobility at all, no movement at all, right? Last one we have, yeah, Lashman is done with the knee at 20 degrees flexion, not 30, it is at 20, okay? And CDH, the congenital dislocation of the hip, we know we have the newborn baby. What test is to be done? It is Ellis, Barlow's and Ortolani, right? Ellis, Barlow's and Ortolani. And definitely one thing, one very important thing which I want to focus upon here is the vascularity. And what do we call that vascularity? It is the vascular sign of Nareth. It is the vascular sign of Nareth. And what is that vascular sign of Nareth? In the posterior dislocation of the hip, we are not able to feel the femoral pulsations. And that is what you call vascular sign of Nareth, which will be positive in two cases. One is the congenital dislocation of the hip, and that again will be same thing in the posterior dislocation of the hip, because the CDH is a kind of PDH only, right? The congenital dislocations are posterior only, and this is what you call vascular sign of Nareth. All right. So this is till here the clinical test. And now coming on to very, very important fractures one by one. What all we can identify, what all we can appreciate. You get this image in your exam. Can you identify what deformity it is? Let's, yeah, okay. How to differentiate between Barlow's and Ortolani? See, Barlow's test is basically done to dislocate the hip, right? What you do, the child is lying supine in front of you. Child will be lying supine in front of you. And let me just see if I have one video to be shown. Let me just allow me a moment and I'll just see if I have that video with me. I'll just show you. See, yeah, I do have. See this one. Okay. So now look at this. What we do in Barlow's test, we are suspecting this child to be having a dislocation. It is a tendency for dislocation actually. In any newborn baby, this same thing can be done. You just hold the thighs of the child, right? Child is lying supine. You are holding the thighs of the child. Just bring them close and give it a gentle push. In none of the newborn baby, the head of femur can be dislocated like that. In none of the child you can do that until and unless there is a tendency. And when will there be a tendency? When this socket which is round like this, it has got a shallowness. When it has got a shallowness. So when you just push the thigh back, the head of femur is going to slide out. Head of femur will just slide out. Okay. And this is what you are calling as Barlow's. So look at this. What is happening? Adduct and push it back. It is going to dislocate. This is Barlow's. And you abduct and pull the hip back to reduce it. It is Ortolani, right? That is the difference in Barlow's and Ortolani. I hope that makes the things clear. Right. That makes the thing clear. Okay, so that was, yeah. So this one, coming back to this, what is this deformity? This is what we call as or label as the cubitus varus deformity. Cubitus varus deformity. So question is, where do we see the cubitus varus deformity? In which conditions do we see that? The cubitus varus deformity is related to what? Everybody is saying supracondylar. No, I am not pretty satisfied with this. It is not supracondylar. It is something more than that. What is that? It is actually the malunion of the supracondylar. It is not supracondylar. It is malunion of the fracture supracondylar. Malunion. Why in supracondylar there should be a malunion? What is the logic behind that? Why? No other complication. Because supracondylar area is what kind of bone? It is a metaphyseal bone, right? And metaphysis has got highest vascularity. Chances of union are maximum here. Colles fracture, Smith fracture, Boxer's fracture, Jones fracture. What are they? They all are metaphyseal injuries. And that is why their healing, their union is best. That is why the healing or the union is actually best. All right. So malunion of fracture supracondylar humerus. So this is what you call gunstock, right? Or the cubitus varus deformity. Then other one, when you talk about supracondylar and when you talk about the lateral condyle, what is the basic difference in between them? The two most important injuries which you must never forget, and you can expect some question definitely from them, right? Maybe in relation to complications, maybe in relation to the clinical presentations. Let's see. So supracondylar injuries, being metaphyseal, being highest vascularity area of the bone, they always have high chance of malunion. They always have high chance of malunion. Lateral condyles always have a chance of non-union. We have discussed that point. Why? Because lateral condyle has an attachment of common extensors, right? So that doesn't allow it to unite. That is the reason why the supracondylers always and always go into some deformity. That is like the varus deformity we are talking about. So union is a surety, but then it will have a gunstock deformity like that. When you look at the lateral condyle, because of non-union, we are calling it as a fracture of necessity. Sorry, we are calling it a fracture of necessity. What are different fractures of necessity we know? What is the meaning of that word, fracture of necessity? Now that's very important. Fracture of necessity are those injuries where answer for you in the exam has to be surgical intervention only. Where answer has to be only surgical intervention. Why? Fixation. Fracture of necessities we know are three. One is the lateral condyle humerus. Second is the fracture Galeazzi. Always operative. Don't think of conservative part, right? Don't talk about the conservative part. And third one is the fracture neck femur. We always try to operate, right? We always want to operate. But not only these, there are certain other fracture of necessities as well, but with a condition. Other fractures of necessities are there as well, which are there with a condition. What are other fractures of necessities which are there with a condition? So please understand there are 2 to 3 important scenarios. What are the other conditions here? Number one, whenever there is a two-part fracture of patella or olecranon, right? Two-part fracture, whenever there is a two-part fracture of olecranon and or patella, right? Why are these called as fracture of necessities? Why I'm not keeping them simply like 1, 2, 3, 4? Because every patella is not a fracture of necessity. Every patella is not a fracture of necessity. It is only and only the two-part fracture. It is only and only two-part fracture, right? So two-part fracture of olecranon and two-part fracture of patella, because always olecranon will be pulled by this triceps, right? Olecranon here, triceps is going to pull it. So that never stays on the position, right? That never stays on the position. Patella, two parts are always pulled by the two muscles basically into the opposite directions. Okay, so two-part fracture of olecranon and two-part fracture of patella. Others are like any displaced intra-articular fracture. Any displaced intra-articular fracture. They are always fractures of necessities. Displaced intra-articular fracture. Any example we can think about? Commonest, Barton's here, right? Displaced intra-articular. Always open and fix them. Always open and fix them. So two-part fracture, olecranon, patella. Displaced intra-articular fracture. And third most important I want you to memorize all the time is classical montagia. Now what is the meaning of that classical montagia? What exactly is the meaning of classical montagia? Same one. Fracture here, proximal 1/3 of ulna and dislocation of proximal radial ulnar joint. That is the radius, right? So classical montagia has both the two. Sometimes there are multiple montagia variants as well, where there is no radial head dislocation and only some break, little break in the proximal 1/3 of ulna. So that will not be damaging, or that will not be that bad with the prognosis as compared to classical Montegia. So all the upper three we have said, these are fractures of necessities, 100% cases, but others are fracture of necessity with a condition, right? Lateral condyle will always be requiring a surgery. Now, supracondylus leads to varus. Supracondylar, it leads to varus deformity. You can see these cases. I'm just showing you some cases, some very bad cases which were not managed well somewhere, and this is what the supracondylar can lead to. You can see this supracondylar tight bandage, forearm having a lot of blisters all around, hand going into claw. So this is what compartment syndrome looks like when it has happened to somebody. Okay, so this supracondylar always have a complication of going into varus deformity, gunstock. Lateral condyle always have a problem of going into valgus, right? So this is the difference in the radial head, supracondylar and the lateral condylar humerus. Okay, that is a basic difference we have in these two injuries, supracondylar, lateral condyle. Then this is one complicated case which I'm just showing you. Now here, if you just look at this, you can appreciate that lateral condyle has not been fixed. There is a fracture, if you can appreciate there. And if you don't fix it, what will happen in the late phase? This lateral condyle will develop as a separate piece of bone, right? So lateral condyle don't unite, it never unites like that because of common extensor pull over here, right? That is not going to unite because of common extensor pull over here. Okay, now these are different stages. Coming on to whenever the supracondylar or lateral condyle, they are making some deformity in the forearm area, right? Moving towards the medial side, towards the lateral side. What are the different angles which can be asked in your exams as the MCQs? So the angles in orthopedics, let's talk about that. What are the different angles we have? So number one, the different angles, these are different one. The angle which is seen around the elbow area, it is Bowman's, right? Angle around the elbow, it is Bowman's. Cobb's angle around the spine, which condition we are talking about? Scoliosis. So in the cases of scoliosis, we talk about the Cobb's. Bowman's will be seen when you are reducing the fracture supracondylar humerus. Bowler's or Gissane, you are seeing in calcaneum for the depressions of calcaneum. When you want to check for depression, whether the calcaneum body is depressed or no, you know very well, Bowler's is somewhere normally between 20 to 40 degrees, and crucial angle of Gissane, we call it, it is somewhere between 100 to 120 degrees. Mare angle, another very fancy name in the foot area for what? Mare. Mare is being seen for flat foot. It is being seen for flat foot, right? Or in CTV, when we are talking about cavus deformity. Between what two bones? Between what two bones? The first metatarsal and the talus. First metatarsal and the talus. So flat foot, pes planus, or the CTV cavus. And Kite's angle, Kite was a person who started treating the patients of CTV. So in the foot area again, this Kite's angle is between the talus and the calcaneum, right? Talocalcaneal angle. So these are different names, different named angles that you should be knowing, and they can be asked as like matching side A with side B, or simply Cobb's was a question of 21 or 20 exam of INI where they gave you one X-ray, the Cobb's angle, and they simply asked it like, what angle is this? Okay, so the Cobb's angle, yes, you're right, it is in CTV. Okay, so next one after the angle, we have this angle, how to measure it. I'm just showing you the pictorial representations. If ever they ask you one line through the center of humerus and other line going through the lateral condyle like this is what you call the Bowman's angle, number one. Number two is Cobb's is in the vertebra. Between the deformed part of the vertebra, we see this is Cobb's angle. Number three, it would be the Bowler's angle or the angle of Gissane, right? The back side, this back slope of the calcaneum is Bowler's angle basically. Okay, and then this one, this side is, it has to be Bowler's. This one on the back is Bowler's, central area is Gissane. So this one is Bowler's, you can see that next one. So Bowler's and Gissane, and then we have the next one, that is Kite's angle between the talus, basically talus and the calcaneum bone, and then last this Mare angle between the first metatarsal and the talus bone. Okay, so these are different named angle. These are different named angles that should be very, very clear to us. Okay, now this was one of the very an uncommon kind of question which was asked in your INA exam. Where do you see the fishtail deformity, right? Where do you see the fishtail deformity? So fishtail deformity will be seen here. You can see the fishtail, it appears like this, right? So whenever in the humerus there's a defect of trochlea, there is a defect of trochlea, we can see this kind of defect in the lower humerus, right? So humerus will be appearing like this only. Humerus will be appearing like this only. So this is the fish tail deformity, right? This is fish tail. Again, INA set exam question. So where do you see fish tail deformity? At the lower end of the humerus. It can be seen at lower end of humerus. Now coming on to this one, elbow dislocation. Which kind of elbow dislocation is this? If you can make out, this is which kind of elbow dislocation? Here the humerus is basically, it is a proximal bone, okay, and the ulna is here, radius is here. So elbow joint is going on which side? So it is going posteriorly. So we are supposed to call it what? This is the posterior dislocation of the elbow. This is the posterior dislocation of the elbow. Now there is one very, very important concept around the elbow called as the 3-point relationship. 3-point relationship. What is that? When I keep my index finger on my olecranon, thumb on the medial epicondyle, and middle finger on the lateral epicondyle. All right. So when I flex my elbow, you all can appreciate that they are making some sort of relation there. That is what we call 3-point relation. And when you just extend it, they all will be in the straight line, right? They all will be in the straight line. Okay. So 3-point relationship, where is it damaged? When is it damaged? This has been the recent session INA question, November session of INA set question. So 3-point relationship is made by 3 points. When either of the point is broken, the triangle will be broken. As simple as that. And so fracture lateral condyle, fracture medial condyle, or fracture olecranon is going to damage the triangle. Whenever the injury happens above the triangle here, it is not going to damage the triangle. So supracondylers, fracture supracondylar will have no change in the 3-point relationship. That was your recent session INA set question. Okay. So this was asked. Yeah, this 3-point is maintained in supracondylar. Perfect. Absolutely. Because the supracondylar injury is here. So it has got no relation with the triangle. Okay. And in any case, the elbow is dislocated and this triceps is pulling this olecranon up. What will happen in that case? In that case, once the triceps contract, it is going to pull the ulnar radius up, posterior dislocation of the elbow. It reverses the triangle. The posterior dislocation of the elbow, it reverses the triangle, right? That will reverse the triangle. Okay. Yeah, perfect. That is a reversal of the triangle. So supracondylar has got no change in the triangle. Now this year 23, we had another question in the exam, and that was about terrible triad of the knee. Similarly, we have terrible triad in the elbow also. How do we define the terrible triad of elbow? It is defined as the elbow dislocation, number 1. Second, fracture of the radial head and the injury to the coronoid. When these three points are involved or injured, in any case, we call it the terrible triad of Hotchkiss, right? So terrible triad of the elbow is by these 3 points: the elbow dislocation, fracture of the radial head, and the coronoid. All right. Now next, let's see next one. This is the terrible triad I'm showing you. This was on farmer who presented after like injury to the elbow, and here you can see the chip of the coronoid here, the chip of this radial head here, and even the chip of the lateral condyle is gone along with the dislocation, right? This is what you call the terrible triad of the elbow. Okay, so this was the AP view for the same fellow. Now leave this. This was a CT report. We got it done later. Now this fracture, one very, very important fracture, and I'm sure you all can answer it. You all can very quickly answer it. What are we talking about? What are we talking about? Okay. Okay. So stress related questions we can have after the sessions. Don't worry. Okay. So right now have that full positivity and energy in yourself. You are completing orthopedics, and that too quickly, isn't it? So what are we talking about? What is this? This is a fracture of proximal 1/3 of ulna with the dislocation of radial head. All right. So there is a nerve which is getting involved here, and that is a PIN. So we are talking about Monteggia. Perfect. Absolutely correct. This one, the reversal of the Monteggia, proximal 1/3 ulna, distal 1/3 radius, proximal radio-ulnar joint, distal radio-ulnar joint, and that is the ulna. Okay. So that is Monteggia and Gallisi. Monteggia and Gallisi, right? Monteggia and Gallisi. So these can be image-based question or clinical questions in your exam. So Monteggia and Gallisi. All right, perfect. Let's see the next one. Distal end of radius. One of the wonderful areas to have MCQs in the exams and the easily solvable ones, right? So distal end of radius, how many injuries we know here? How many injuries do we know? So distal end of radius here and here, you can see them. The fractures Okay, so fractures distal end of radius, they are basically, when you look at this X-ray, they are basically of two types. Fracture distal end of radius, they are basically of two types, extra-articular and intra-articular. Now see the difference, extra-articular and intra-articular. When you look at this extra-articular, when you look at this extra-articular, how do you make out? Okay, tell me one thing. Everybody is so like Colles. Okay, let's see which one is Colles. Tell me which one is Colles. This is image A, this is image B, this is image C, and that is image D. Tell me which one is Colles. Okay, tell me which one is Colles. Now when you look at the image A and B, you can very well make out that image A and B are like outside the articular margin. They are not going into the articular margin, isn't it? So articular margin is absolutely all right. Here the articular margin is absolutely all right, isn't it? The articular margin in the picture A, in the X-ray A, it is going towards the thumb, going towards the palmar side, right? Going towards the palmar side. So A, Pranav, you are wrong here. Vishnu again got, yeah, this one got, everybody else is catching it right. So now please see this distal radius going towards the palmar side. What does it make it? This is the Smith fracture, right? And if it is going on the dorsal side, what does it make it? Image B is actually Colles, and that is the reason why the deformity that you see here is called as what? The garden spade. And the deformity that you see on the back is called as, the deformity that you see on the back is what you call as the dinner fork deformity, right? That's the dinner fork deformity we have. All right, so Colles and Smith. So image A, X-ray A is of Smith, X-ray B is of Colles, X-ray C, you can see here, is the breach in the intra-articular margin, a piece of the bone getting detached from the bone, comminuted injury, displaced intra-articular injury, and this C is what you call as Barton's. The C is Barton's, and D is what? The injury to the fracture to the radial styloid. And what do we call that? That is Schoffer's, right? That will be Schoffer injury. Okay, so these are four we have: the Colles, the Smith, the Barton, and Schoffer. These are four injuries we have. Okay, I hope we are all clear. So those who answered Colles, so it is not Colles. Colles and Smith are intra-articular. No, Colles and Smith. You see the articular margin. Can you see that? Articular margin is clean. How can they be intra-articular? Okay, intra-articular are the Barton and Schoffer. Okay, so extra-articular and intra-articular. So this one is away from the joint. This one is also away from the joint. So these two are extra-articular injuries. So Colles and Smith are away from the joint. In the Barton, the joint line is breached. So it is intra-articular injury. All right. So that is one. Perfect. Fine. Now next, so Colles, Smith, Barton, and Schoffer. Next one, this is what we are calling as the dinner fork deformity. This is what we are calling as the garden spade deformity, because the fragment here is going back. So it is creating a hump on the back. This is creating the fragment to come in front. So this is the garden spade deformity. All right. So garden spade and Colles. How to identify Colles and Smith? Oh, this is what we have just done. How to define is on the basis of their displacement. So when the displacement is happening, when the fragment comes on the palmar side, we call it Smith. When the fragment comes on the dorsal side, we call it Colles. So when somebody falls down, keeping the hand like this, the impact happens here and the fragment goes back. That is why Colles is the most commonest fracture that happens overall at any age group, right? Distal end of radius is the commonest fracture which happens to anyone at distal end of radius at any age group. Okay. So Barton's is a fracture of necessity with a condition. Perfect, Vivan. Wonderful. You've got it absolutely right. Okay. Let's see the next one. Scaphoid. So much to learn from here. Scaphoid. We know that scaphoid is the most commonest carpal to get fractured. It is the most commonest carpal to get fractured, right? When you label scaphoid, it will be the distal pole of scaphoid. It will be the proximal pole of the scaphoid, and fractures most commonly happen in the scaphoid where? At the waist area, middle pole area. And you know one very important point about it, the radial artery, it enters back from the distal pole towards the proximal pole like this. Retrograde kind of blood supply. That means if the waist is having the fracture, who is losing the blood supply? It is the proximal pole which loses the blood supply, right? It is the proximal pole. So avian is very common where? Avian is common in the proximal pole. All right. And if avian is common in the proximal pole area, how will you examine the patient clinically? Clinical assessment will be tenderness here. Where? In this area. That is the anatomical snuff box. Tenderness in the anatomical snuff box. Okay, tenderness in the anatomical snuff box is like classical for the scaphoid injuries. Okay, it is classical for the scaphoid injuries. Okay, so scaphoid should be the most commonest carpal you should mark if they ever ask you, and tenderness in your patients, if it is given clinically to you in the snuff box, it has to be from the scaphoid only. So distal pole, middle pole, and proximal pole. All right. Now scaphoid and like the other bone, when you talk about the scaphoid, please remember one very important point about the scaphoid. The most commonest complication related to scaphoid injury, it is not avian. Most common complication has to be non-union followed by avascular necrosis. So non-union and avian are the most commonest complications. And for both of them, what is the best investigation we can do? It is always good to go with the MRI part, right? It is always good to go with the MRI part. Now, MRI indications. I know it is a radiology topic and the radio faculty can teach this much better. But yes, when it comes to orthopedics, the questions in the exams, you have to catch it very quickly. So remember, what are the indications for MRI when you talk about the orthopedics part? See, there are 4 I want you to remember. Number 1 is always the soft tissue injuries. Number 1 is always any sort of soft tissue injuries that might be happening. Okay, number 1, rotator cuff tear, muscle damages, any soft tissue injury like ligaments. Okay, any of the injuries like muscles or the tendons, both of them, muscle, tendon, ligament, right? All the soft tissue by always and always by MRI. Second, when you are talking about any of the cartilage lesion, when we talk about any of the cartilage defect like meniscal tear, like osteochondritis, like when there is a osteochondroma, so when there is a tumor of the cartilage, injury to the cartilage, inflammation of the cartilage, anything of cartilage by MR. Second, the third one. Third is MRI is the most sensitive investigation. Sensitive, I'm saying. I'm not saying specific. Please be very vigilant here. I'm not saying specific. I'm saying sensitive. Sensitive means the investigation which tells you about the changes that yes, it has happened. Right? Sensitive is the one which tells you about the changes. What changes can we see here? The change will be marrow edema. The change will be marrow edema. Okay. And this marrow edema is very important for 2 most important things. One, when you are talking about stress fractures, when we are talking about osteomyelitis, the first thing, the first change that you can see in any radiological investigations in infection in 24 hours is marrow edema. So for infections and for stress fractures, initially, the best thing that we can get done is the MR. And last, the number 4, I'm saying here is avian. Avian which can happen because of trauma, like in the cases of scaphoid, neck, femur or talus, or whenever you are having some other local regional conditions like Perthes, like CDH, like SCFE, these all can produce the avascular necrosis. So soft tissue injuries, cartilage defects, stress fractures and osteomyelitis, and number 4, avascular necrosis. These are 4 more most important topics, conditions where you have to answer your this option you have to take as MRI only. All right. I hope it is fine. The MRI part, the MRI indications. Now, second bone here, the lunate. Scaphoid, we talked about the fractures. Lunate is a bone which will undergo dislocation, and it is very common to undergo dislocation. Distal end of radius, and the lunate standing out. Right? Lunate standing out. This is what you call lunate dislocation. Rest of the carpals are in position. Right? This is what we sometimes call as the spilled teacup sign, as if a cup of tea is falling out. Right? That is a spilled teacup sign. Right? Second one is a perilunate dislocation. This was a NEET question 2018. Perilunate is all the carpals have, migrated or shifted dorsally like that. And lunate is subluxed volarly. Lunate is subluxed volarly. Okay. So when lunate dislocation is there, it is only the lunate which is dislocating. Perilunate means all the carpals are going dorsally and lunate sublux anteriorly like that. Okay. This is what we are calling as spilled teacup sign. Right? So whenever the scaphoid and lunate, the ligament between them are broken, scapholunate dissociation, scapholunate dissociation, something like this. This is normal scaphoid and lunate. Okay. And now this is what happens. The scaphoid and lunate now away from each other. What is that called as? The Terry-Thomas sign. Right? The gap between the front 2 teeth, that is Terry-Thomas sign. All right. So scaphoid is the bone to get fractured. Lunate is the bone to get dislocated. Perilunate and lunate, the difference has to be very clear. right? The perilunate and the lunate, difference has to be very, very clear between the two. Okay. All right. So, all right. Next one we have is yeah. Next one we have is the injury at the base of first metacarpal. What is that injury at base of first metacarpal? We have got two injuries here. First metacarpal, the base here. We have got two injuries here. What all? One is Bennett and other is Rolando. One is Bennett and other is Rolando. How to differentiate Bennett and Rolando? Bennett is a partial intraarticular fracture. Bennett is partial intraarticular, one fracture line going there, and attached to this distal part is a very important muscle, and that we call as what? The abductor pollicis longus. So if you now recall, APL has got three questions for you, right? APL has got three questions for you. What are those questions? One, the inflammation of the APL and EPB. What did we call it? Decurvane stenosynovitis. Second, the bone that it can displace, the one in front of you, that is Bennett. Third, the nerve supply is the exception here. The abductor of the pollicis, the longest one, is getting a supply from radial nerve, not from the median nerve, right? So APL nerve supply, radial nerve. APL displaces which fracture? Bennett's fracture. APL inflammation with the EPB is called as what? The decurvane stenosynovitis. Okay, these are three important questions from the APL part. All right, the fifth one, the next, actually the last in the hand area we have is Boxer's injury. What is a Boxer's fracture? It is the fracture of the neck of fifth metacarpal. Fracture of the neck of the fifth metacarpal, and that's what you call as Boxer's injury, right? That would be the Boxer's injury. Okay, yeah, all right, okay, that is Boxer's injury. So now this is all from the upper limb part, and I'll explain the difference in a lunate and perilunate. Okay, I'll explain that. Let me go back to that image. See the difference between the lunate and perilunate. First of all, you should be able to identify which bone is which one here. Okay, so when you just identify, look at this. I'll mark the black boundary for the distal radius. This is a distal radius. You all can appreciate that. Second one, this is the bone standing out is lunate, right? So only the lunate, when you draw this axial line here, it is cutting all the carpals. That is a straight line. When you just see the other picture, distal radius here and lunate is still trying to articulate with it, but all the carpals have gone back. That is perilunate dislocation. All right. So lunate and perilunate. Lunate and perilunate. That is the difference. Okay. So KK, are you okay with that? So we will have to just hold on for a while now. Just hold on for a while. Okay. Just hold on for a while and the link has to be changed. So guys, those who are in the YouTube, now you're asking me like when, till when it is going to be there on the YouTube. So till here, we are going to be on the YouTube, and now the rest of the part is into the DBMCI live only. So you will have to just allow me, the guys on DBMCI live, just allow me some 2 to 3 minutes or 4 minutes, and we are just shifting the link to the DBMCI live app only. And those who are there with me on the live, yeah, Bennett and Rolando. Yeah, Bennett and Rolando can be Lavish. Yeah. I have seen your message. Look at this. Rolando is comminuted fracture. See, Rolando is comminuted intraarticular fracture here, and Bennett is a partial intraarticular fracture. Okay. So Lavish, if that is okay, I am answering to both the doubts, Raymond. Okay, I'm there on the Telegram itself. So I have multiple devices in front of me. So one is keeping YouTube alive, one is keeping the Telegram alive, and that's how the world is going now. So many devices you have to keep. Okay, so I'm there with you as well. So Terry Thomas, I told you, and spill teacup when you're asking me. See, this is spill teacup. This is what we call a spill teacup. When the lunate, look at the last picture. If you can see that, lunate is falling out. So this is spill teacup. Okay, so now we will have to just spill teacup means as if this tea. See the third picture. Rachna, see the third picture. Okay, third X-ray just over my head here. Can you see that? Yeah, in the lunate. It is in the lunate dislocation. All right, so we will just hold on for a while and the links will be stopped. Okay, and then we are continuing on the DBMC live. So just allow me some 2 to 3 minutes. The team will be working on it. Can be done. So just give us 3 to 4 minutes or maybe like little time, and I'm here only. Okay, I'm just waiting for the studio team to do the needful, and then we continue on the DBMC live. The or rest of the part of the orthopedics, your lower limb, your spine, and then rest of the tumors, infections, and so on. So same way, I'm going to just cover up. Just hold on for a while. Thomas test, the